Hello, everyone. My name is Christy Amobi, and I work in the product division with Xstrahl Radiant, and I will be the moderator for this event. In today's session, we will be providing a short introduction to electronic brachytherapy and superficial radiation therapy, and review how these treatments can be used in a dermatology practice for non-melanoma skin cancer. I will be joined today by Lori Hortzman, who is a clinical application specialist with Xstrahl. She will be providing the main presentation. After Lori's presentation, we will be answering questions that you've submitted through the questions tab of the GoToMeeting webinar. If you have any questions, please go ahead and enter them at any time, and I will moderate those at the end of the presentation. Thank you for your attention, and with that, I'll hand it over to Lori.
Thanks, Christy, and good morning, everyone. I've been asked to give a short presentation about radiation therapy for skin cancer, and more specifically, how it's presently being used in dermatology. I just want to briefly contrast high energy and low energy radiation. Hospitals are using electrons to treat their skin cancers, which are high energy, defined in the megavoltage range, meaning they do treat surface, but they also can treat much deeper tumors with a deeper presentation. As you can see on the slide, for eBt, we're talking 50 to 70 kV. For electronic brachytherapy and for SRT, superficial therapy up to 150, although anything higher than 100 is not typically seen in a dermatology office. With low energies in the kV range, we're still able to deliver very safe, very effective treatment. The penetration of the beam is effective up to a maximum of 5 millimeters with rapid dose follow-up from that point. At these energy ranges, a lower distance, there's very little scatter and the room requires little to no shielding. Both eBt and SRT are used in direct contact with the skin, so you're delivering dose only to the area that you're treating, sparing surrounding tissues. It's a great option for many patients for a number of reasons. Patients may not be good candidates for surgery due to some medical conditions or areas that may be slow to heal or somewhat difficult areas to treat. So why is surface therapy important? Well, it gives dermatologists another option for patients that have small, early stage non-melanoma skin cancers. It's non-invasive. And for some patients with small non-melanoma skin cancers, it's still a great option. A short series of low-dose treatments have proven to have excellent curative and cosmetic results, usually 8 to 10 treatments. We'll talk about that. As mentioned previously, there may be instances where surgery is contraindicated, patients on blood thinners, patients with diabetes, physical limitations, or maybe just some general poor health. There are patients who also may be concerned with scarring in sensitive areas, or maybe they have a history of poor wound healing. They're also really good candidates. And patients may want treatments that require less time in the office. We've had recent feedback from some physicians suggesting that patients want to spend less time in the office because of COVID, believe it or not, which is something we hadn't even thought about. But even in the absence of COVID, some patients did like that office visits were much shorter than surgery. And as we know, dermatologists have history with using radiation in their offices, and there's really been a resurgence of radiation therapy in dermatology practice. So most states are allowing dermatologists to deliver surface X-ray therapy in their own offices. If radiation's a good option, patients really appreciate not having to go to an oncology department in a hospital for treatments of their very small skin cancers. So as we said, eBt and SRT are very safe, effective, convenient. Who qualifies for treatment? The National Cancer Care Network, NCCN, has one set of established guidelines for eligibility. There are several others. Since it's been used so long in different modalities, there's quite a volume of literature that support long-term results. We did mention that the effective depth is 5 millimeters, but eBt and SRT are really for superficial lesions, so they're usually treated at 0.5 to 3 millimeters. Lesions from 1 to 4 are representative, maybe 90% of lesions treated. We also have 5 to 8 cm applicators available, and those are clinically accepted by your peers. Skin reactions are minimal. Patients get some redness. It doesn't seem to show up until halfway through the treatment. Sometimes a little crusting, but really very minimal side effects that go away quickly. Overall healing takes 2 to 4 weeks. Many times reaction is completely resolved, or closely completely resolved, at about the 4-week mark. Long-term effects also minimal. 5-year evaluation may see some redness, or on the opposite end of the scale, some hypopigmentation, but no scarring. The actual treatment time when the patient is in the office, the time that the machine is actually delivering the dose, is very quick, slightly over a minute, sometimes less than a minute. And the patients really can be in and out of the office in 15 to 20 minutes. So this is just showing electronic brachytherapy, and SRT therapy as well is direct contact. So both of them are referred to as surface radiation therapy. Surface meaning it's directly on the skin, and shorter SSD, which SSD is the source, which is in the head of that machine, to the skin. If you treat with a very small SSD and contact therapy, there are very tight margins around that applicator. So you really just treat the lesion with a small amount of margin, and it's a very tight edge. So eBt is the lowest energy range, 50 to 70 kVp. So with using such a low energy, it enables you to give you a higher dose per fraction. And I should repeat that. With low energy, you give a higher daily dose. This means a treatment course can be finished in 8 to 10 fractions, usually twice a week. 8 to 10 based on clinical factors. Again, there's literature and guidelines for that. Some of the most commonly used fractions are listed there. 400 to 450 centigrade to a total of 4,000, 4,500. 700 times 6 is on there. That's not used often, but sometimes for elderly disabled patients who just kind of want to finish quickly. So SRT uses a slightly longer SSD and slightly higher X-rays. Because of those two factors, a lower dose per fraction is spread out over more days. It also requires a slightly larger margin, not much because of the increased lesion, and it's still a lot less margin required with other units that have quite a bit larger SSD. Typical dose fractions, again, just represent the 300 times 15 fractions to the same kind of total, 250 times 20. They can be treated 2 or 3 times a week. So I want to talk about the Radiant a little bit. The Radiant is a dual modality capable of both eBt and SRT in the same system. It really gives you the flexibility with patients' insurance coverage. Most insurances allow small lesions to be treated with either SRT or eBt. Applicator size and filters are easily switched out for the two modalities, make it very easy to set up patient treatments. And our company, Xstrahl, is an established company. We're not new. We've been making radiotherapy units for many years and have 700 worldwide. With the Radiant here in the US, we're providing all of the customer support really for setting up your program, training, and onboarding. So just a review of our technical specs. Lower dose and shorter SSD, lower energy that is, and shorter SSD. For eBt, slightly higher energy and longer SSD for SRT. And I just want to discuss a little further what we meant about those tight margins at the end of our cone, our applicator. So we have Penumbra here. I'm going to use my pointer. Penumbra describes the edge of the field where the dose can drop off compared to the 100% at the surface. With a higher SSD, longer of other machines, sometimes 15 to 25, just kind of picture a flashlight. The further you get away from this point, the larger it diverges. So this area of dose fall off becomes a lot more. And so in those cases with a larger SSD, you have to treat a lot more margin around the tumor to get the tumor covered with 100% dose. With our shorter SSDs, as in the 5 for eBt, very, very minimal. We're seeing 0.5 to 1 cm margins, slightly more with the SRT, but not much. So all this tissue, healthy tissue here is spared. You get to treat just the tumor only. And I wanted to make mention of our treatment software. This is just the initial screen. Software is called Concerto. On this screen, you're inputting a new patient as well as your treatment parameters. Prior to treatment, the patient's field is outlined and simulated, and the treatment plan is prescribed by you. The applicator size, the daily dose, total dose, treatment time. The parameters are input, and a second approval is required before treatment can proceed. And what this means, and it's a positive thing, you have a second set of eyes, double checking everything that you may have put on your prescription. And the second approval is done and the treatment can proceed. After this, second approval never needs to be done again. The patient's exact treatment is recalled every day, and you move on from there. There's no possibility of using the incorrect applicator, filter, treatment time, because interlocks are there to prevent all that. So it really makes it minimal chance of any kind of human error. And other benefit is it pretty much acts as an EHR, or record and verify. It records your treatments every day, keeps it in the software. You can print those out, network to other computers sometimes. It stores the patient record. You can always recall what was treated before. So you also cannot extend, if you prescribe 10 treatments, you cannot extend beyond that either. It's another interlock that prevents you from doing that. Oh, Dr. Davis, one of our users in San Antonio, he's been using it for about 8 months, and he likes it so much he even made a video for his patients. He's ended up treating more patients than he really thought he would, and we've had a lot of positive feedback for him. Dr. Pomerantz is another user in Las Vegas. She actually used to have a different treatment unit and decided to try the Radiant out and really likes it, especially for the shorter treatment times. Patients are happy with it, and from our standpoint, the quicker the treatment time, the less time patients have to move. So it's best to be able to get that treatment done quickly. Our installation and setup, our machine is very small and it's light. It's very easy to move around. You can see that arm extends, it rotates, the head will rotate also in a lot of directions. So it's very versatile as far as aiming anywhere on the body. Again, the room should not require any shielding, sometimes some additional drywall, which we take care of as far as the onboarding process, and low startup costs, which I'm not the salesperson, you'll have to talk to him. Your training is on-site, hands-on. We stay on-site till you treat your first patient. And that should be everything I need to tell you. So in summary, you can treat both eBt and SRT. It's safe, effective. It's non-invasive. Our software is really nice, really keeps your workflow reliable and efficient. And our dual modality is probably the best feature about the Radiant.
All right, thank you, Lori. That was really helpful and informative. Just a reminder to all of you on the line, for those, especially for those of you who joined late, that's okay. If you have any questions, you can submit those via the questions or chat function of the GoToWebinar. And I'm going to go ahead and moderate those questions. So we have a few questions coming in right now. And is 20 or more fractions really needed for SRT? As I know some are prescribing.
Clinically, no. The literature is showing, equal cosmetic and curative results. The 20, there's radiobiological factors as far as extending it out, which are up for debate. During each treatment, the cell cycle continues. So one of the theories is those cells have time to repopulate. And by continuing on, you actually can get yourself some more skin reactions. So if it's not necessary, and then, why do it? And then patients coming in those extra treatments is sometimes a burden as well. But those are all, clinical decisions that you can refer to literature. But that's what I've seen, my experience.
Okay. Next question. What are the real advantages / benefits of electronic brachytherapy versus superficial and vice versa? Do you see sort of one being more advantageous in certain situations versus the other treatment method?
Well, electronic brachytherapy is so nice because a patient can finish in 8 to 10 treatments and only twice a week. Sometimes those SRT treatments are usually 3 times a week at least. Some people do more. So it really progresses quicker. The skin reactions are, still minimal. The patients look really great. The long-term results, I mean, the healing at 4 weeks, the results I've seen are just incredible. So that's the hugest benefit right there.
Okay, and this is another question from an attendee, is kind of related to this one. Is there sort of certain situations where you might prefer one over the other?
I would say anytime a patient needs to get done quickly, if that's their preference, their insurance coverage will take it, then that would be the preference, I think, all the way around.
Okay. Another question, are the state regulations the same for both modalities?
More and more the states are classifying both together as surface radiation therapy. It's just become more mainstream, especially our machine, because it's really just an X-ray tube. So it's not a live source or anything like that. So the state regulations have different classifications. They may say surface, they may say a machine under 100 kV, this is how we regulate it. But yeah, pretty much it falls in one of those 2 categories of surface, and then it's fine.
Okay. A question about the software. Does the software export to billing?
It doesn't right now. It does. You can export PDFs or print PDFs. So I've seen that happen. You can print a PDF daily to upload into your EHR, which I'm sure the most EHRs that I've seen out there would be Emma. So you can either do it daily or you can do a summary at the end. And I don't think, as of now, we can't network. Some of the different systems within the hospital may network, but also not for billing.
Okay, the second question here is related to that. It's around charge capture. Does the system automatically capture any EBT codes or?
Yeah, no, it does not.
Okay.
But the EHRs, inherently have them. The codes for EBT are all there.
Okay. Okay. Back to sort of indications and clinical outcomes, you mentioned some of the data in your presentation. Are the published cure rates the same for both modalities? Have you observed any differences in that area?
Yes, they're very closely the same. Of course, there's so much literature out there, but yes, they're the same, and they're comparable to surgery.
Okay. Shifting gears a little bit, this is a training question. What does the training look like for a dermatologist who doesn't really have experience with radiation therapy?
Well, as part of the setup process and complying with all the state regs, there's a lot of education along the way as far as radiation safety and quality assurance. And we talk a lot about the workflow and how we're setting that all up, and it really clarifies how that is all supposed to go. The on-site training is at least a day and a half, where we go through the operation, everything from the operation of the machine to the software, which is really intuitive and easy to learn. And we stay through the first round of patients, and we're always available real time if you need support. Someone's always available.
Okay, this is somewhat related. It's regarding our current customers' experiences. So what have you observed as the biggest obstacle for dermatologists getting started, and how have our current clients been able to overcome the obstacle?
I wouldn't say obstacles. Some of it is time consuming, making sure it's really important to make sure that you're complying with all the state regulations and they know that you understand that, because they will come in and just monitor. They'll come in to inspect your program, or they'll talk to you at least. So it's time consuming. It's just a little time consuming. Not overly long, but it's not, you can't plug in the machine and start tomorrow is the kind of deal. We bring in, physics has to verify the shielding of the room and that everything's safe, and that's something you want anyway. So, but we guide you completely through that process.
Okay, that's a good question to the next, good segue to the next question. Does the room need to be lead lined?
No, it does not. At the most, we're seeing that we may have to add an extra layer of drywall, but that's very dependent on what's on the other side of those walls. Are there offices next door? How long are they used? Is one of the walls brick that goes to the outside? But the most we've ever seen is maybe add a layer of drywall. And again, physics comes in and actually does a whole room survey. It's required by the state anyway. Comes and does a whole room survey with a survey meter in the room, outside the room, everywhere. That has to be, documented legally. It has to be documented.
Okay. During the presentation, you talked a little bit about indications. This question is related to that. What size lesions are typically treated with Radiant?
We have, of course, we don't treat anything smaller, than a 1 cm. We wouldn't treat a half cm. It'd be hard to aim and shoot on that. But we have applicators up to 8 centimeters, and other ones could be available by request.
Okay. Let's see here. Another question. This is more of a sales question, so if we need to address this at a later time, let me know. It's is the dual modality machine more expensive than say only having SRT?
No.
Okay.
Both are inherent in the system. Both energies are available with the same system. All the systems are dual modality, no matter which you decide to use.
Okay. And this is related to a previous question, but I'll just ask it anyway. You talked about treatment times. This attendee asked, how fast can patients really get in and out of the office?
Well, of course, there's so many variables right down to how far is the waiting room from the treatment room. Seriously, geography matters, but you know, it really seriously 15 to 20 minutes. They schedule people 15 to 20 minutes if they're being, I'd say 15 and is what they're scheduled. If there is a second lesion or third lesion, of course you schedule a little bit more time, but it's very quick. The treatment beam itself being on for a minute takes a little more time to get everything set up and verified. The software is an issue. The software is very quick. So just taking your care with the patient is what takes the longest, the 15 minutes.
Okay. Let me just take one more skim here of the questions. I think I got everybody's. Is there anything, Lori, that you'd like to add that we haven't covered or that hasn't been addressed in the questions before we conclude this session?
Oh, I just wish that I've been clinically, I am a therapist as well, and I wish people could see the results that we have and that we've seen, not even really over the last 5 to 7 years in the field. And I think at some point we'll be able to be providing some of that through these webinars, correct, Christy?
Yes, we will.
At some point we will. So the results really are amazing. I'd have to say they just really are amazing. People are very pleased, especially on the face, nose, cheek, scalp, all those areas.
Okay, well, thank you again, Lori, for providing this introduction for us today. Thank you again to the attendees for your attention and the time that you took out of your schedule to join us. On behalf of Xstrahl, I'd like to thank you and wish you a great rest of the week, and thanks for your attention.